have to change that bio. I feel very old when it says 25 years experience listening to it. Thank you everyone for joining. You've all probably had busy days. So I was just saying to Kathy before, sometimes people don't want to jump online and watch a webinar after you've had a long day at work, but this webinar is one of 5 in our series. So it's really an interesting one. It's probably the most popular webinar, and of course at this time of year with spring having just arrived, you may have seen it presented by us in previous years. I stopped my video because I've had a bit of trouble with bandwidth over the last couple of years, so I just stopped the video for the moment. I'll come back on when we go for questions halfway through, but yeah, as Kathy said, please type any and all questions into the chat box or unmute yourselves. No questions too hard or too silly, and we should be finished by about 8 o'clock. All righty, let me stop video and on my screen. Okie dokie. So tonight we're going to, by the end of this session, be able to describe the association between allergic rhinitis and asthma. We're going to summarise the treatment guidelines for allergic rhinitis. You'll be able to describe those people who are at greater risk of thunderstorm asthma and be able to think about and discuss the guidelines of management. And we'll also just summarise the importance of written asthma action plans and asthma first aid in thunderstorm asthma season. Just to start with, I like to just show the website for the Australian Asthma Handbook. So the Australian Asthma Handbook provides best practice, evidence-based guidance, translated into practical advice, if you like, for us health professionals. There's minor and major updates. The last update was in April last year. We're currently going through a big update, which will be probably out halfway through next year. But it's updated regularly, and our guidelines are written by a committee of respiratory experts. It's available free online for everyone to access. So if you've not seen it before, or even if you have, I encourage you to jump on there. Anything and everything to do with asthma and a little bit on COPD can be found there. Then we have the National Asthma Council website. So any of the resources that you see tonight, any charts or information papers, they'll all be available on this website to download as a PDF. You can actually email us and we can send you out hard copies as well. Now, first of all, let's talk about allergic rhinitis. So approximately 19% of Australians suffer from allergic rhinitis, or also known as hay fever. And 11% of people in Australia have asthma. So relatively speaking, 19% who have allergic rhinitis is a large number. Allergic rhinitis is often underdiagnosed, undertreated, and suboptimally self-treated. It's most common in those between 15 to 54 years of age, and it's an independent risk factor for developing asthma in children and adults, and the presence of allergic rhinitis is associated with worse asthma control. Most people with allergic rhinitis are sensitized to multiple allergens, so for example, both pollens and house dust mites. So symptoms may be present throughout the entire year. And the most common allergens are house dust mite, pollens from grasses, trees, or weeds, animal dander, and mold spores. So they're the most common. Both rhinitis and asthma can be triggered by the same factors, whether they're allergic or non-specific. So non-specific could be cold air or strong odors, perfumes, environmental tobacco smoke. And allergic rhinitis and asthma commonly coexist, and it's sometimes referred to as the United Airways disease. Asthma obviously is inflammation of the small lower airways, and allergic rhinitis is inflammation in the epithelial lining of the upper airways. Allergic rhinitis occurs in more than 80% of patients with asthma, and asthma occurs in 30% of patients with allergic rhinitis. So it's obviously important to assess patients with rhinitis for coexisting asthma and treat both the conditions. Don't just treat the one. Some patients can mistake symptoms of allergic rhinitis for asthma and vice versa. But allergic rhinitis is sometimes more easily recognisable only after asthma has been stabilised. So when we assess a patient for allergic rhinitis, we would assess common symptoms, and they could be local symptoms such as nasal discharge or congestion or itch. They might have regional symptoms, which have effects on the ears and the eyes, the voice and the throat, including that constant throat clearing. And they might have cough from postnasal drip. And then we have systemic symptoms as well, which include sleep disturbance and lethargy. So the frequency of symptoms can be seasonal or perennial. Seasonal, which is mostly in spring and summer, although with the environmental changes, we are finding that people do suffer allergic rhinitis in some different seasons now. But the seasonal allergic rhinitis are triggered by those pollens from the grasses, trees, and the weeds, whereas non-seasonal, year-round, perennial allergic rhinitis can be triggered by those indoor allergens such as the dust mite, molds, and animal dander. When we think about impact of symptoms, people with mild allergic rhinitis, generally there's no effect on their day-to-day function. They can still go to school, go to work, play sport, not have many effects. But those with moderate to severe allergic rhinitis generally have impaired day-to-day function. So it's important to identify a patient's triggers. Not only might they be the grasses, the animal dander, but they could be occupational triggers as well. So different chemicals or irritants or fumes. And these symptoms usually resolve when they're away from the workplace. So spray painters, for instance. So we would conduct a physical assessment and we would inspect the upper airways for things such as swollen turbinates, transverse nasal crease, as you can see in the diagram there, more common in children. They get that term, we call it allergic salute, from that frequent rubbing of the nose in an attempt to relieve itching. So they get that transverse nasal crease. We also assess for reduced nasal airflow, or our patients' mouth breathers. Do they have dark circles under their eyes, indicating sinus congestion, for example, or they might have sinus pain. And we take a relevant history of coexisting conditions such as asthma and eczema. So hay fever, asthma, and eczema are all extremely closely related. So there's two main allergy tests that can help to identify allergens and enable a precision approach, I guess, to managing that trigger. And the gold standard diagnostic investigation is serum-specific IgE blood tests. And they obviously detect specific IgE antibodies. These antibodies are made, of course, by our immune system against allergens such as the dust mite, pollen, molds, foods. So this blood test, you may have also heard it be called the RAST test. So when a GP or other health professional are ordering these blood tests, they need to write specifically what test they would like, what allergen they want tested. Otherwise, just a small panel of tests is completed. The second allergy test that's common as a diagnostic investigation is skin prick testing. This once upon a time used to be the gold standard, but now it's flipped with the blood testing. But the skin prick testing can be completed by the GP or the practice nurse or an allergy specialist. That's where we put small amounts of different allergen solutions applied to the forearm or the back with a dropper, and then we gently prick the skin with a sterile lancet. So if a patient has a sensitivity to a particular allergen, the skin swells or develops a welt like you can see in the picture there. And it's important to educate our patients if they're coming in for skin prick testing that they need to avoid antihistamines for 3 to 4 days prior to the test. Tests that aren't generally useful are food allergy testing, FBE, and kinesiology, reflexology, hair analysis, things like that. So it's really important for patients to speak to, or people to speak to, a health professional. They might not yet be a patient. They need to speak to their GP, respiratory nurse, practice nurse, allergist. They shouldn't simply rely on over-the-counter remedies. So these are a list of the different treatments that are available. So we'll start at the top, and the intranasal corticosteroid sprays are by far the most effective treatment for patients with persistent or moderate to severe intermittent allergic rhinitis. The intranasal corticosteroid sprays reduce inflammation in the lining of the nasal passages. They also reduce swelling and mucus production in the nose, and they can also reduce ocular symptoms as well. And some of these are available without prescription, but the stronger versions are available on script. Intranasal corticosteroid spray should be taken regularly, and they need to be taken long-term, just like preventers for asthma. They don't provide immediate relief from symptoms. In fact, patients won't feel relief for up to 2 weeks. So it's imperative that they stick to their dosing regime to gain maximum benefit. Then we have antihistamine nasal sprays. These are available over the counter, and these provide that quick relief of symptoms such as itching and sneezing. Some of them will help with a blocked nose, and relief is usually within about 15 minutes. So the antihistamine sprays are not as effective as the intranasal corticosteroid sprays in controlling that severe nasal congestion and drip. And they don't need to be used regularly to be effective, but rather they can be used as symptoms arise. And they can control symptoms for up to 24 hours these days. It used to be 12, but the way they're producing or manufacturing the medications, most of them now can control for 24 hours. Then we have combination sprays. So as the name suggests, they're a combination of the corticosteroid nasal spray and an antihistamine. So there's Dymista and Ryaltris. They're the two most popular ones out there on the market. Dymista's just become available without script. So it's now an S2 and available over the counter, which is very handy. And then there's Ryaltris, which is only available on script. And those both give the advantage, obviously, as I said, of the antihistamine and the intranasal corticosteroid. Then we have antihistamine tablets, and most of us have all had antihistamine tablets before. And these are effective for controlling itching and sneezing, but they're less effective for clearing that blocked nose that comes with most people's allergic rhinitis. And I'd just like to say here that if the response to an intranasal corticosteroid alone is inadequate, despite regular daily use and correct spray technique, we can always add an intranasal antihistamine and continue the intranasal corticosteroid as well, or of course swap over to the combination spray. And it's not mentioned in this list, I must add it in, but I'd like to also just quickly mention decongestant nasal sprays and tablets. Of course, they're used to unblock the nose, but they shouldn't be taken for more than a few days at a time, as they can begin to actually have a rebound effect and cause nasal passages to become inflamed and swollen and congested, which is what we don't want. So 2 to 3 days at a time, they can be useful. Then we've got the saline sprays and rinses, which are not the most pleasant procedure, but they can be effective. They help to flush away allergens and irritants from the nose and keep the nose clear by loosening and thinning the mucus. So when symptoms improve, treatment with any of these treatments can be reduced. And allergen avoidance is obviously advised once the allergen or as allergens have been confirmed. And allergen immunotherapy, otherwise known as desensitization, may actually be a preferred option for some patients rather than medications and sprays. So desensitization, for those of you who don't know, is the regular administration of allergen extracts. It can be performed sublingually nowadays or subcutaneously to promote clinical tolerance, and treatment is usually for 3 to 5 years to produce ongoing benefits. So it's quite a commitment and can be a little bit more costly as well. It requires referral to an allergy specialist, but it is the only treatment that can alter the allergic response. So 3 to 5 years, as I say, is quite a commitment, but some people are happy to commit to that for long-term effect. We avoid oral corticosteroids in allergic rhinitis. They're not justified due to adverse reactions such as hypertension and increased blood clots. But there are allergy treatment plans available, and I'm about to show you those. We also have NAC how-to videos, which are on the NAC website that I showed you. So our how-to video library demonstrates correct device use, not just for asthma medications, but for nasal sprays and sinus rinses as well. And these are really handy for us to refer our patients to have a look at, because correct technique is so important. For instance, with the intranasal corticosteroid sprays, if GPs or nurses don't have the time or simply forget to instruct a patient on how to use them, and patients don't direct those sprays away from the nasal septum, they can have ongoing blood noses. That nasal septum is very vascular, so it's important to correctly educate our patients in using those devices. So looking at a couple of the treatment plans now. So the allergic rhinitis treatment plan on the left is from the Australian Asthma Handbook, and the one on the right is from the ASCIA website, which is the Australian Society of Clinical Immunology. We use these with patients in combination in most cases. So if we have a look at the left-hand side, patients with intermittent symptoms that occur seasonally may only require treatment for a few months of the year, so they'd be mild intermittent. So we might start them just with an oral antihistamine or a Montelukast, review them in a couple of weeks and see if they're controlled or uncontrolled, and follow that step down. For those patients, though, who have severe symptoms occurring seasonally and are related to pollen exposure, they usually require long-term treatment. And we would start intranasal corticosteroid sprays at least 2 weeks before the onset of the pollen season. Then we could add on an intranasal antihistamine. We could consider short-term addition of those intranasal decongestants for 3 days or so, or oral antihistamines. Then we'd review those patients in 3 to 4 weeks and follow that flow chart down. The intranasal corticosteroid sprays are not on PBS, but they range from $20 to $50. They used to be over $70 when I first started consulting with patients, so they have come down in cost, which is really good. Then on the right-hand side, we've got the ASCIA chart for allergic rhinitis, and it is more like an action plan for asthma, where you actually write down the patient's medications. There's a little diagram on how to use them correctly, and basically how to increase them if symptoms persist or increase. This is our allergic rhinitis treatment chart, last updated at the end of last year. And it was really only updated because of a couple of packaging changes, but it's still current now. But always keep an eye on the National Asthma Council, I should say, website for updated charts. It's normally once a year that they do get updated. This is just another couple of resources here. On the left-hand side, the allergic rhinitis treatment planner. That's actually a tear-off pad and is really handy. It gives basically all of the treatments here on one side, and then a plan on the back of that A4 page. So there's about 20 pages to a pad. And then on the right-hand side is intranasal spray technique information paper, which is also really handy to have. It's being updated currently. So even though it says 2017, it's pretty much everything is still relevant. We've just added in, or we are adding in, the couple of new medications there. So a couple of really great resources to share in your clinics. So when we think about specialist referral for rhinitis, if we haven't seen a response to treatment trials within 3 to 4 weeks, we would then need to consider referring our patients on. Their allergic rhinitis symptoms may be persisting. They may have become more severe. There may have been no response to treatment at all with intranasal corticosteroids or combination sprays. Our asthmatic patients may be experiencing persistent or increasing symptoms with their asthma, or they might have poor asthma control despite regular preventer medication, and they may have had good adherence, good inhaler technique, good nasal spray technique, but we just can't get them on top of their symptoms. Other allergic diseases such as eczema may be present, which may not have been dealt with in the past either. So that's when we think about referring on. We'd also consider referring when a food or an occupational allergy is suspected, especially where symptoms are worse at their workplace. And referral might also be required to an ENT specialist rather than an allergy specialist for complications that a patient might have, such as unilateral or bilateral resistant obstruction, or they might have sinus disease, or they might have lost their ability to smell. They may have ear problems or persistent purulent discharge. Excuse me. So there's always an option to send to an ENT specialist as well. And of course, referring on to an allergy specialist if immunotherapy or desensitization is required, because they are the people that need to order the allergen bottles. All right, I'm just going to have a look in the chat box and see if there's any questions. If anyone has any questions, feel free to type it in or unmute yourselves and ask me. I'll just give us a minute. Chance at the end to have any questions answered as well. There's nothing in the chat at the moment. Like there's any coming through, so I'll close the chat box and we'll keep going. So now we're just going to talk about thunderstorm asthma. All right, so grass pollen season, which in southeast Australia typically occurs from October through to December, brings a seasonal increase in asthma and allergic rhinitis. So even though spring has started, we say that grass pollen season actually doesn't start until the 1st of October. So pollen season brings the chance of thunderstorm asthma, and thunderstorms occurring throughout October, November, December can trigger asthma in people with grass pollen allergy, even if they've not had asthma before. Thunderstorm asthma can affect those with known asthma past or present, or those just with seasonal allergic rhinitis. And this slide shows us a timeline which is particularly relevant for you guys tonight. I don't always show this if I'm obviously presenting to other states, but it's still handy to know with climate change and everything. I think thunderstorm asthma will occur not just in southeastern Australia, but you probably all remember the November 2016 thunderstorm asthma event that occurred here in Melbourne. It was the largest event of thunderstorm asthma over the past 4 decades, and the largest event ever reported worldwide, in fact. So we had severe thunderstorm activity here in Victoria. It was November 21st. It led to thousands of people suddenly having asthma attacks, finding it hard to breathe. And as you may remember, our emergency departments, Ambulance Victoria, were completely overwhelmed by the volume of people suffering from asthma exacerbations. People were presenting, calling up, needing urgent attention all at the one time. And the median age of the majority of those affected back in 2016 was 32 years of age. So you can see from the slide, the table there, that the history of all these events is in the month of November. And the time of the events and the presentation to emergency departments is relevant. For example, in 2011, the thunderstorm sort of rolled in the middle of the night, around 3:30 in the morning, and there were only 30 emergency department presentations. Whereas in 2016, the thunderstorms rolled in around 6 p.m. in the evening, and there were actually more than 3,400 presentations to emergency departments. So people were coming home from work, from uni, they were outside, it's daylight savings, so people are out and about, coming home from sport, and so many people were affected. Other reported Australian episodes, as you can see down there, again, New South Wales, Canberra, and several incidents recorded internationally as well. So following the 2016 epidemic thunderstorm asthma event, general practices, not only ED and Ambulance Victoria, but general practices in the Melbourne metro area experienced a considerable impact. Over the 3 days from the 21st to the 23rd of November, so 2 days after the thunderstorm asthma event, there were an estimated 10,000 additional asthma cases visiting GPs. In the 30 hours following the event, there were 3,400 extra emergency department presentations to public hospitals in Melbourne and Geelong, and that's a 672% increase above the 3-year average. There were 500 extra admissions for asthma to public hospitals in Melbourne and Geelong. There were 30 ICU presentations, and tragically, there were 10 deaths. So not only were emergency departments, Ambulance Victoria, and general practices inundated, there were also a large surge in pharmacy presentations. And salbutamol was in short supply. In fact, a lot of pharmacies ran out, as did some of the public hospitals here in Melbourne. 2/3 of the patients who presented to hospital actually didn't know that they had asthma, but when they were further questioned in the hospital, half of those reported having previous asthma symptoms, including the shortness of breath, the cough, wheeze, nighttime waking. And then some patients were discharged from the hospitals, whether they were admitted or just from ED, and they weren't properly followed up in primary care. They failed to make review appointment with their GP, so it just became an absolute disaster. So we're hoping that that never happens again. So what is it about the springtime conditions that brings on thunderstorm asthma? Well, for a thunderstorm event to be significant, it needs to be a high pollen day. Not all spring thunderstorms lead to thunderstorm asthma. It also is dependent on a change in humidity and a drop in pressure. So I mentioned before about November, and the perennial ryegrass, that common pasture crop, it's what's been implicated in all Australian thunderstorm epidemics. And you can see here, for example, the November 2016 or September to November 2016 Victoria rainfall map, where you can see the light and the dark purple shading. They represent higher levels of rainfall throughout those 3 months in 2016. So there's high concentrations of allergenic material. It's mainly ryegrass pollen, but it could also be fungi or dust. So this slide shows a visual representation of one hypothesis and the main hypothesis out there for the mechanism of thunderstorm asthma, and how if it's a high pollen day, the clouds, obviously in the thunderstorms, can deposit smaller than usual particles in the air, and therefore the potential to cause problems for those with asthma and or allergic rhinitis. So whole pollen grains get swept up into the cloud as the storm matures, and these pollen grains are normally about 10 micrograms in size, so we can normally filter them in our nose. The moisture in the cloud fragments the pollen into smaller pieces, usually less than 2.5 micrograms in size. Then the dry, cold outflow then carries these much smaller pollen fragments to ground level, and these are not filtered in our nose and therefore are more easily breathed into our small airways. So the strong wind gusts that precede a thunderstorm provide a really efficient mechanism for exposing large numbers of people to lots of pollen allergens suddenly and at the same time. And then depending on the storm's movement, these gusts can travel over large areas before diminishing. Then large numbers of people are affected by asthma. They will have symptoms at similar times, and that's where we get the term epidemic thunderstorm asthma. I'm just going to show, This is just a little graphic of those 10 microgram sized pollen particles being broken down in those thunderstorm clouds into less than 2.5 micrograms. So you can see how much more easily they are inhaled into our small airways. Remember, this is in ryegrass pollen season, so between October and December, but most occurring in November. So who's at risk? Well, there's a few different categories of people. Firstly, it's people with sensitization to ryegrass pollen. Then there's people with seasonal allergic rhinitis related to grass pollen who have asthma or who have never had asthma. Then we have people with asthma, especially if they are poorly controlled or not taking their preventer medication. Other people at risk are those people with a past history of asthma. For example, they might have had childhood asthma, but they still have that hyper-responsiveness in the airways, and due to those very small pollen particles, their old asthma, if you like, gets triggered. So they're also at risk. Then there are those with undiagnosed asthma. And the risk increases even further in patients with both asthma and allergic rhinitis who are poorly controlled or who have previously been admitted to hospital. So these high-risk categories of people, when they're exposed to open air before and during a thunderstorm in pollen season, or who live in areas prone to high pollen, are all at increased risk. And evidence from the 21st of November 2016 event suggests the higher risk in Southeast Australian populations. So it's really important for health professionals, particularly in Victoria and the lower half of New South Wales, to be aware, to educate their patients, teach them what to look out for. Such things are the Oz Pollen app. In Victoria, we've also got the Aerator app. It's a wonderful thing having these apps now. The Australian Pollen Allergen Partnership is a website. Also the Vic Emergency website, which will but warn people about thunderstorm asthma or thunderstorm events that are going to be upcoming in the next few days. Also the New South Wales State Emergency Service. They're just a few that I've listed. So we want people to avoid outdoor exposure when the pollen count is high and the thunderstorms are predicted. If they're going to be in a house or in a car or at their workplace, they should be closing their windows, turning off air conditioning units unless it's on recirculated air. So evaporative cooling is bad. So on those days of high pollen or thunderstorm events, they should be staying indoors. If there's any signs of asthma, they need to follow a personalised asthma action plan, or if they don't have a personalised written asthma action plan, then they need to follow the first aid steps, which I will get to in a moment. So medical management of asthma and allergic rhinitis. So those people who have both. We need to be proactive, and they need to be proactive as well. So they should have a review appointment. They shouldn't just wait for something to happen. They need to come in, see their GP, and have their written asthma action plan renewed, and also their allergy plan renewed as well. We need to ensure they have a correct diagnosis of asthma and allergic rhinitis, of course, but we also need to know that they understand their triggers and their management for their triggers. So we would address both lifestyle and medical management of asthma and allergic rhinitis. They need to take prescribed medications. They need to start it early enough. They need to understand their reliever therapy and the importance of adherence, and they also need education on correct device technique. We need to provide advice for high pollen days and thunderstorm events. So they need to be managed and regularly reviewed. And as I said, they need to start their preventer medications, whether that's for asthma or the intranasal corticosteroids, at least 2 weeks prior to and then throughout the pollen season. So they need to be pretty much commencing those medications now and continuing them through right to the end of December, the 31st of December. They also do need to carry a reliever medication with them. We need to educate them that they need to replace it before the expiry date and before it is empty. I know that sounds like common sense, but you'd be surprised at how many people don't look at the expiry date or even realise there's an expiry date. And they'll come in to me and they'll say, oh, I'm not getting any, and I have a shake and it's empty. We also need to encourage proactive treatment for allergic rhinitis, which I've said. So those intranasal sprays, not just the asthma medications, and just encourage them, to say or to recognise that, it's not just asthma, it could be allergic rhinitis as well. Give them those stats of the 80% people who suffer asthma and allergic rhinitis, and really drive home to them that they need to treat both conditions. For those people with allergic rhinitis but no asthma, we need to manage them according to the current allergic rhinitis guidelines. So again, they need to be commencing their intranasal corticosteroids at least 2 weeks before and continue right throughout the pollen season, so mid-September right through to the end of December. These guys with allergic rhinitis will have allergy to ryegrass pollen, so they're definitely at risk, as I've said, for thunderstorm asthma, but particularly if they're travelling to or living in a region with seasonal high pollen grass levels. Even if they've never experienced asthma before, they are at risk. So we would educate them on thunderstorm asthma, give them an explanation of how to recognise asthma symptoms and what to do, know how to get a reliever medication, educate them on correct device use, provide asthma first aid information because they may not have a written asthma action plan if they only suffer from allergic rhinitis. So we need to educate them what to do should asthma symptoms start. For those people with no seasonal allergic rhinitis or no asthma, or they're lucky, but we just need to reassure these people that their risk is low and really raise awareness of their asthma first aid. It's also handy for people to know asthma first aid so they can assist people with asthma in the community. You know, the more lives will be potentially saved in an asthma emergency event, the more people that are educated. So I'd just like to touch on the importance of written asthma action plans. And we've got to remember that, I guess, asthma is really frightening for both a child or an adult who suddenly gets symptoms, but it's also frightening for the parents or the carers as well. So severe or life-threatening asthma exacerbations are more likely to occur in patients with inadequate medical supervision. And whilst an action plan isn't medical supervision, it's not always possible to see a GP in the middle of the night or to get to an emergency department, especially for rural and remote people. So written asthma action plans clearly explain the steps to take to manage a person's asthma day to day and what to do during an exacerbation or asthma emergency when people can't get to the GP or to a hospital. So the action plans should be individualised. I know that goes without saying, but again, you'd be surprised at what I've seen dealt out to patients in the past. So they need to be individually written so that each person with asthma can recognise deterioration of symptoms and how to respond appropriately. So it is expected that all children and adults with asthma have a current asthma action plan. They need to be reviewed 6 monthly for children and 12 monthly for adults. They should contain the person's usual asthma medications, including treatment for related conditions such as allergic rhinitis. So this is where we can actually add in to an action plan their allergic rhinitis treatment, or we can give them the Askia plan as well as the asthma plan. The plans need to have clear instructions on when to take extra doses of medication, how to change their medications, including when and how to start a course of oral corticosteroids. The plan also should include when and how to contact a doctor or to go to the ED in an emergency if they are close enough to get to one. The name of the GP or the other health professional preparing the plan needs to be written onto the plan, and also the date that the plan was issued. I also like to provide advice about epidemic thunderstorm asthma, where to access pollen counts and forecasts, and just jotting down a couple of those apps or websites is really beneficial to our patients. So action plans have been shown to improve health outcomes. They significantly reduce the rate of visits to acute care facilities. People miss school or work less often, and they wake less at night and have improved symptom scores. And as I say, they significantly reduce ED and hospital presentations. As I said, they need to be reviewed every 6 months for children and every 12 months for adults. We have the National Asthma Council action plan on the left-hand side there, and the Asthma Australia plan on the right-hand side. So these are true commonly used written asthma action plan templates. You can also find them on Medical Director or best practice software. And they're available from the NAC and Asthma Australia in particular in different languages as well. They're available in colour and in black and white, because we realise that not all GPs are going to have a colour printer in their office. But yeah, everyone needs to have one, especially coming into asthma season, as I say. For those out in the community or even in pharmacies, this is the community first aid protocol, also known as the 4x4x4. So we give 4 separate puffs of SABA via a spacer. SABA stands for short-acting beta agonist. So that's your reliever medications such as Ventolin or Asthma. We get the person to take 4 breaths per puff, and then we wait 4 minutes. If symptoms persist, we repeat those steps. So 4 separate puffs of Ventolin, for example, via the spacer. We get the person to take 4 breaths per each of those puffs of Ventolin, wait 4 minutes, and repeat. If there's still no improvement, we'd be calling an ambulance, or preferably getting someone else to call an ambulance, because we're often the person who's administering the medication for them. So these 2 charts are available on the NAC website. We've just updated them in the last 6 months or so. So we obviously have one that you can see there for children under 12 and one for those 12 and above. So short-acting beta agonists are the most commonly used in asthma first aid. So as I said, the Ventolin, Asthma, Zemprion, but some acute care facilities, i.e. emergency departments, are now starting to use Symbicort. So Symbicort is a combination medication. It's got a reliever component and a preventer component in it as well. The fact that it has the reliever component enables it to be used as a reliever medication in community first aid. And those charts are available on our website as well if you want to go in and find those. But still most commonly these days it would be a Ventolin or an Asthma that's used. So how do we prepare for springtime thunderstorm asthma season? If you're in a clinic situation, which most of you in the audience tonight are, I believe, we need to prepare early. So proactively review those patients with asthma, especially those with history of springtime asthma or allergies, or if they've had previous thunderstorm asthma event. You could complete a database search and even take the chance to have a telehealth consult. I think telehealth's stuck around, even though we're sort of a bit more relaxed with our COVID restrictions now. But be aware of high pollen and thunderstorm weather forecasts, and in the clinic, put posters up, have little pamphlets. You can list some of the different websites and apps, and you'd be surprised at how many people take a little pamphlet or just an A5 sheet of paper. We need to ensure in our clinics, as we've learnt the hard way from the 2016 event, to have sufficient supply of Ventolin, Asthma, Zemprion, Bricanol, that they're all in date as well and not about to expire or have expired. We also need to ensure a plentiful supply of spaces. Obviously, if worst came to worst, you'd reuse the spacer between patients, but that's not ideal. So have a plentiful supply of spaces. And I'm not sure if you've heard or seen of Light Airs. They're a collapsible cardboard spacer, so very easy to store in your clinic as opposed to the Breathatex, which obviously take up a lot more room. So that's an option if you wanted to contact your medical suppliers for all those spacer options. Also important to have a clinic policy for patients presenting with asthma exacerbations, and all staff, including the receptionists, your practice nurses and GPs, should be aware of their responsibilities and trained up in asthma first aid. Have your charts on display, have brochures on display in your waiting areas. Most beneficial. As much advertising as you can do, it's never going to be a negative. Even put an article in your monthly newsletter or weekly newsletter, whatever you have, if you have one, and really promote that awareness. I also just like to mention the Asthma Australia 1-800-ASTHMA program. That's a free, confidential health service delivered over the phone by trained respiratory educators through Asthma Australia. It's a really handy number to give to patients. I often write it on the bottom of our action plans so that if they do have exacerbations, they might not be having too serious an exacerbation, but they might not be able to get into their GP, which we know is becoming more common. So I like to just give them that number as well. If you're out there in the audience tonight and you're from a pharmacy, we like to remind people that they need to have spaces, again, in adequate supply. Obviously, they need their reliever medications or SABAs in plentiful supply. We also have a flowchart available on the NAC website under resources for all staff, including pharmacy assistants, dispensing technicians, and it really is handy for them to know their responsibilities and to prioritise these patients and to be able to provide asthma first aid, again, just like in a clinic situation. Again, for them to have charts on display, and also handy for them to know which GP clinics are open and able to assist if appropriate. For patients who come in, we really like pharmacists and people who work in pharmacies to know a bit about hay fever medications, either the intranasal corticosteroid sprays or antihistamines, but also to ask patients who come in about their asthma symptoms, and definitely to recommend GP review if asthma symptoms are identified. You can always ask people, have they experienced asthma exacerbations before? Did they experience an asthma exacerbation in the last thunderstorm asthma event in 2016? Lots of different questions like that. Don't just hand over medications. It's always better to ask a couple of questions. So another couple of thoughts to consider. Does your clinic or your workplace have an emergency asthma action plan policy? Sorry, not action plan, emergency asthma plan policy. I've got action plans on the brain now. Who has responsibility for different aspects of care? Is there a consistent approach to emergency asthma management? And does everyone in the practice know where reliever medications and spaces are kept? And there's a few more suggestions there in the Asthma Handbook website if you wanted to have a look. Just a couple of resources that you can find, obviously the Australian Asthma Handbook, but on the National Asthma Council website, the action plans that you've seen, medication charts, not only the allergic rhinitis medication chart, but the asthma medication chart is there too. It's just been updated. The first aid charts that I've just been through with you, thunderstorm asthma for pharmacists flowchart, managing allergic rhinitis in people with asthma, which is one of the resources I showed with the tear-off pad earlier, intranasal spray technique. You can also find the how-to device video library, and also spirometry infection control recommendations are on the National Asthma Council website as well. And I also, considering we're in Victoria tonight, just like to run through a couple of the resources that are available through the Department of Health. They have a great thunderstorm asthma public health campaign, which aims to ensure that all Victorians, and in particular people with asthma and oral hay fever, are as prepared as they can be should another thunderstorm asthma event occur. So there's some really handy resources there as well. We're just having a look at those. That's the end. So I'll open the chat box again. I'll just take it back to that page in case you want to use your phones to take a photo of there. Let me have a look in the chat. Did anyone want to type in a question or unmute yourselves and ask a question? I'll turn my camera back on. Put my glasses on so I can see what I'm looking at here. That's it. All right. I'll keep the chat box open. Was there anything else that you wanted to add, Kathy, while we're waiting for any questions?
No, that's all good. I think it was really good. Yeah, just a reminder for the evaluations tonight or tomorrow, whenever you get a chance this week, just send them through and we can provide the certificate of attendance for tonight's session. Yeah.
Great. It doesn't look like anyone's sending anything through.
No, I don't. think
Oh,
so.
there's one there. Actually, there's one. Can you please tell me, sorry, put my glass on. Can you please tell me the name for the handy spacer? So we've got the light air spacer is the rectangular cardboard spacer. It's collapsible. They're really handy to have in the clinic. You get them in, I think, a box of 20 or 30. Sorry, I should know that off the top of my head. But a whole box basically takes up the same amount of room as maybe 2 or 3 Breathotech spaces. So Bird Healthcare provide those or sell you those. Bird Healthcare are also my go-to for the little La Petite E chambers, which are only about this small. Then you've got the next size up, which are the Breathotech. So I probably wouldn't be storing any larger than a Breathotech in a GP practice. You just wouldn't have the room. But the light air, so LITEAIRE, the light air spaces are the really good ones. And then you can give it to the patient as well to take home with them. So that's handy. There is another question here. When doing a data search, what would you search? So you can do data searches either by typing in medication. So you can do a database search on Ventolin, or you can type in if someone's had a history of asthma and it's typed into their actual file that they've had asthma, you can do a database search on that as well. You might like to target adolescents, so just put in the age brackets. So you might do 14 to 18-year-olds. You could also put into the search box allergic rhinitis. So there's lots of different ways. I'm not sure if there's someone at the PHN, Kathy, who might have other ideas on database searches as well. But yeah, start with asthma diagnosis, allergic rhinitis, all the different medications, and you should find that a lot of patients come up. I think that was the only I got a thanks. That's okay. Any other questions that you wanted to type in while we've got the chance? How are we going for time, Kathy?
Well, it's it's 2 minutes to 8, so we definitely have time. Yeah.
Other good things, I'm just trying to think what else I can say if anyone else is typing a question. Little tips and tricks on households, wet or damp dust. Don't use a duster. Always wet a cloth to dust. That will always help people with allergies, especially if they've got a dust mite allergy. Don't get rid of your pets, obviously, but don't have pets on beds, because bedding is the big source of dust mite. And of course, allergens. Also soft toys. A lot of children love to have all their soft toys with them when they go to sleep, but they harbour huge amounts of dust mites as well. So just get your patients to ask their children to just have, one teddy per night or something like that. Mattress protectors, pillow protectors, things like that. So if you want any more tips and tricks, that can also be found on the National Asthma Council website as well. Doesn't look like there's any more questions coming through, Kathy. So I guess we can probably leave it there.
Yes. Yeah. Okay. Well, thank you so much, Narelle, for the talk tonight.
You're welcome.
I will be sharing the video recording in the coming week. Yeah. So if anybody else has any other questions, I'm assuming in the next week, maybe Narelle, I could reach out to you to answer. Not sure.
Yeah, that's fine. Yeah, send any questions through the email and you can send them through to me. That'd be fine, Kathy.
All right. Have a good night.
Thanks, everyone. Thanks for joining. Thanks, Kathy, for hosting.
Thank you. Bye-bye.
Bye.